This is a very high yield section where a lot of the different questions are going to stem from. So what's really important here is that we get down the differences in the mechanisms and then some of the very classic disease processes that present with each of these 4 different hypersensitivities. So we'll start at the top and work our way down through the different types. So when we're talking about the type 1 hypersensitivity, we're typically going to be talking about more of an allergic type of reaction. And you can see, allergic contact dermatitis, for example, with type 4 hypersensitivities. But in general, when we're talking about allergies, allergens, we're talking primarily about type 1 hypersensitivity. Okay. Now, in this category, the classic causes are going to be patients that are allergic, again, to certain foods, right? So again, we're talking about allergic. So patients that are allergic potentially to certain foods, to certain medications, or a history of some type of insect sting, all very classic for this kind of allergic reaction. And the concern when you have these allergic reactions is that this allergic reaction can kind of tip the patient over into anaphylaxis, okay, specifically anaphylactic shock. So that's what we're worried about in these patients. We don't want them to get to the point where their blood pressure drops and we don't have organ perfusion, right? Because of this massive widespread reaction. And that's where the name comes from, right? We're hypersensitive to something, whether that's, peanuts, shellfish, certain medications. The classic one, when you're talking about medications, these patients can be allergic to penicillins, they can be allergic to cephalosporins. But for each of these categories, there's usually like a classic drug that fits into that type of hypersensitivity. You'll see what I mean as we go through this. Sulfa drugs are going to be very classic for the type 1 hypersensitivity. That's not to say that you can't get certain other types of hypersensitivity reactions with sulfa drugs, but kind of the classic one, when in doubt, is going to be more of the type 1 hypersensitivity. And then insect stings, certain foods, very, very classic for causing these kind of allergic reactions, these type 1 hypersensitivities. So what exactly is happening when you have a type 1 hypersensitivity reaction? So let's go through that really quickly. So the thing that you really want to understand here is that there's 2 kind of steps to this. There's the initial exposure and then there's the subsequent exposure. Okay, so let's start off with an initial exposure. Okay, so the initial exposure we're going to kind of just do in this green color here. So we're going to start off with some allergen. Okay, now an allergen, you might be saying, what's that? An allergen is essentially just an antigen. And we've talked a lot about antigens up to this point. So you can essentially think of the allergen as an antigen, just to keep things simple, because that's really what it is. Okay, so it's some antigen that's floating around in the blood. Now let's just make things simple here. So we can just say that we had a patient potentially here that just got, some insect sting for the first time, right? They got a bee sting, and our patient with the bee sting, when they had this inoculation of the sting, there was some allergen from that sting potentially that eventually got into the body. Now, this allergen is going to get recognized by the antigen presenting cells. And this could be antigen presenting cells in the skin. If we're talking about, inoculation from a sting, it could be antigen presenting cells in the blood if we're talking about a reaction to a sulfa drug. In any case, we have an antigen presenting cell. It's going to recognize this allergen and it's going to bind it, right? So it's going to bind it. It's the unique fit on its receptor to bind this allergen. This antigen presenting cell is then going to go on to bind to some naive T cells and say, hey, look what I found. And remember, this T cell receptor is going to be complementary in terms of its binding to this antigen. And what type of receptors are we talking about specifically here? So we have our MHC2 receptor. Okay, now you might be saying, well, how did you know that was MHC2 receptor? It's an antigen presenting cell, right? Antigen presenting cells will display MHC2 to bind to antigens. Remember, all nucleated cells also have MHC1. But for this antigen presenting cell to display the antigen on MHC1, that antigen presenting cell would have had to have been infected, or we might have something going on inside the cell that would cause it to present it on MHC1 through the endoplasmic reticulum, right? And those are all things that we've already talked about, so I won't go into too much detail on that, just kind of bringing it full circle here. But again, because this antigen presenting cell recognized this extracellular allergen, it presented it on MHC2. And if it's presenting it on MHC2, then this naive T cell that recognizes it must recognize it on a T cell receptor that has a CD4 positive co-receptor. How did I know it was CD4 positive? Remember your rule of 8s. 2 times 4 is 8, right? MHC2 times 4, that's 8. This is a CD4 positive T cell. And this is where I want you to just stop for a second, because this is where test writers can trick you. very easily, right? Because they can say, look, type 1 hypersensitivities, what are you thinking about? You're thinking about antibodies. In general, when we're talking about hypersensitivities, the first 3 types of hypersensitivities are all going to primarily involve antibodies, okay, immunoglobulins. But when we get to type 4, the type 4 hypersensitivity, we're going to be talking more about T cells. Okay, so the question is are T cells involved in a type 1 hypersensitivity? The answer is actually yes, T cells are involved. This whole process is going to be primarily antibody mediated, but to get to that point, to get IgE antibodies, which you'll see in a second, we need T cells. Okay, so don't be fooled. You still need T cells to make IgE antibodies. You can't class switch, right, without T cells. We've gone through all of this a few times, in the video series so far. So again, I don't want to talk too much about that. You can go back and check out the other videos, but that's the concept. Okay, so we still have T cells involved in some way. All right, so let's recap. So we have some allergen bound to this antigen presenting cell, now presented to this naive T cell. Okay, and now once we have that presentation occurring, that T cell then becomes activated. That T cell, what it will do is it will find a B cell, again, with the same kind of receptor binding to that allergen or antigen. And we have our T cell receptor here, right? So we have our T cell receptor again, T cell receptor, and then here you can see this immunoglobulin on the B cell, right? That tells you it's a B cell receptor. Remember, the immunoglobulins are going to essentially be the B cell receptors just bound to the surface of the B cells. We talked about that in the B cell lecture. Now, what's this thing down here? This is going to be a very important CD40 ligand, right? So here's your CD40 ligand, and here's your CD40. And again, we talked about all of this in the previous videos. This is going to be responsible for that co-stimulatory signal so we can get class switching to occur. We get this signal, interleukin 4 and interleukin 13. Now remember, these are high yield cytokines that are responsible for class switching from IgM to IgE antibodies. Okay, so now you kind of see where this is all coming full circle, why IgE is so important in this type 1 hypersensitivity. In fact, I would go as far as to say that IgE in general is probably the single most high yield thing to remember when you're thinking about type 1 hypersensitivity. Okay, so we make these IgE antibodies from interleukin 4 and interleukin 13 from class switching, right? Now, those IgE antibodies, what are they going to do? These IgE antibodies can then bind to the surface of our mast cells and our basophils. So it doesn't just have to be a mast cell, it could be a basophil here too. But the point is that these IgE antibodies are going to bind to the mast cell and basophil. And you can see what portion is binding to the mast cell and basophil. This is where the devil's in the details kind of thing, right? So these receptors here that you can see, this red-orange receptor, that's going to be the Fc epsilon receptor, okay? And it kind of sounds complicated, but the way that you can kind of think about this is FC, right, is just talking about this portion of the antibody. Remember, you have your antibody, and remember, this portion is your FC, your constant region, and then you have your Fab region out here. Okay, so this FC is just saying that, hey, this receptor binds to the FC portion of the IgE antibody. That's really all it's saying. And then the epsilon, I just remember epsilon with IgE, right? Epsilon receptor. Okay, so that receptor is on the mast cell. That's this structure right here. Okay, so that receptor is going to bind to, again, the Fc portion of the IgE antibody, meaning that the Fab portion of the IgE antibody is going to be sitting out on the top of the cell. So when an allergen or antigen comes around in the future, it will bind to this Fab region, and when it does that, these IgE antibodies can cross-link, causing degranulation of your mast cell. Okay, so all of this stuff in green was the initial exposure, right? We got these antibodies put on the surface of our mast cells, of our basophils, all because of this process, because we were, stung by a bee, for example, or we took a medication that we were allergic to, right? And the antigen presenting cell presented it to the naive T cell and caused this cascade to happen that ultimately resulted in sensitized, that's the key word, mast cells and basophils. Sensitized because now they're sensitive to this allergen. So if this allergen were to come in the body again, if I got stung by a bee a year later, right, or if I took that medication a year later, I'm going to have a much worse reaction because now all of these IgE antibodies that I created are sitting on the surface of my mast cell and basophil. So this is going to be the re-exposure. We'll do this in purple. Okay, so this is the re-exposure. So now I'm being re-exposed to this antigen, right? This is a second time, or maybe a third time or fourth time, but you can see now these mast cells are already prepared. They already have the IgE antibodies that we formed from class switching on their surface, causing degranulation. And what are we degranulating here? This is going to be primarily histamine, okay? That's going to be the big one to remember. And you have to kind of remember, what are the effects of histamine? So histamine can cause bronchoconstriction, bronchospasms, vasodilation. It can cause increased permeability in the capillaries, so you can get some edema, right? And those are some of the features that we see clinically. The big, presentation thing to look for is going to be urticaria in general. Okay, so urticaria is very classic for type 1 hypersensitivities in particular, or some kind of allergic reaction that's kind of disseminating throughout the body. Now, urticaria is also sometimes called this wheal and flare type presentation. So that's another kind of term you can see is wheal and flare. And the wheal is going to be kind of these areas of central pallor, where we get whitening essentially. That's the wheal. The flare, right? You think fire, flare. The flare is the red area around the wheal. So it's all of this red area, right? That's going to be around those areas of pallor, those wheals. Okay, so that's the wheal and flare. And this lesion is actually going to be raised a little bit. And that's because we're getting a lot of fluid in the superficial dermis, right? So as we have increases in vascular permeability and vasodilation, we're getting fluid leaking essentially into the superficial dermis. So that's what urticaria is. Now just be careful here too, because there's also angioedema, which you can also see here because of the vasodilation and vascular permeability. One technical kind of aspect to this is, remember, urticaria is going to be, we have fluid in the superficial dermis, where when we're talking about angioedema, we're talking about fluid deeper, usually in the dermis, usually in the subcutaneous tissues. Okay, so just a little thing to remember, when you're talking about the two of these. Now, like we said, the concern is that this can eventually lead to anaphylaxis, anaphylactic shock. Okay, so that's why this is taken extremely seriously. The even more concerning part is that it happens so quickly. So remember what I said, right? If you have a re-exposure, you already have everything set up for this patient to just degranulate their mast cells and their basophils, because you already have all these IgE antibodies set on the top of your mast cells and basophils. As soon as that allergen comes in, they're going to degranulate. So it happens immediately. So that's why sometimes the type 1 hypersensitivity reaction is sometimes called the immediate hypersensitivity reaction, because it happens so quickly. Everything's already set up. You put the allergen back in and you get instant degranulation. And then again, like we said, the concern is that can go straight into anaphylaxis. So that's why this is taken very seriously. All right, let's just recap the mechanism here. So pretty much what we talked about in the early stages of this happening, again, there's going to be some previous sensitization, which is all of this kind of initial mechanism that we talked about. And then what happens is you have the IgE Fc portion bound on your mast cells and basophils. That's exactly what we saw right here. That IgE Fab portion is going to bind to the allergen like we see here. And then eventually we'll have some cross-linking, right? We have some cross-linking that we talked about, and we degranulate and we release histamine. So we can see the degranulation here right after we have our cross-linking. Now, there's also going to be some release of tryptase. And you might be saying, well, what does that do exactly? Well, the thing that I want you to remember about tryptase is that we can actually do a serum sample for tryptase. Let's say that we have a patient that comes in, right? Maybe they were exposed to something they think they're allergic to, and you might be concerned that this patient is kind of moving quickly towards anaphylaxis. What you can do is you can draw serum tryptase on them, and this will give you an indication as to if they're in fact at risk of anaphylaxis. So that's just one thing to remember in terms of the diagnostics. In general, though, when you're talking about things like anaphylaxis, it's usually more of a clinical diagnosis. You're looking for things like urticaria, difficulty breathing, shortness of breath, edema, etc. Now, the thing that is a little bit less high yield than what we talked about here, but has come up occasionally, is the kind of what happens in the later stages. What happens hours after you're exposed to this antigen? Because remember, the early phase are things that are happening immediately, right? We already have everything we need to degranulate. But later on, we do get some release of prostaglandins, leukotrienes from the arachidonic acid pathway. And a lot of this is potentiated through eosinophils. Okay, now you can see when we went through this mechanism, I kind of skipped this step here, where the B cell can go on to release interleukin 5. And remember, interleukin 5 is very classic for stimulating eosinophils and eosinophil growth. And that's exactly what happens. These eosinophils are just a little late to the party, though. Okay, so when you get questions on type 1 hypersensitivities, remember, you might have an eosinophilia, but classically, the eosinophils are going to be the late stage players in the game. Okay, so they're not going to be things that are happening in the early phase mechanism. That's probably the highest yield thing to take away from this. And these all eventually also contribute to to inflammation. And I think we already kind of talked about the presentation here. Again, generally the more mild presentation, which can potentially lead to this severe anaphylaxis if not treated. And typically when we treat these patients, it's usually going to be with something immediate like epinephrine. Now, if it's more mild, you can think about things like antihistamines, right? Because the problem is that you're releasing histamine, right? So if you give somebody an antihistamine, that should have some effect into kind of minimizing some of these more mild symptoms. And again, this sometimes will take a little bit of time to kind of kick in, and there's different antihistamines, there's different classes. Just know that a lot of what we're targeting here is primarily going to be at the H1 receptor, okay? And we don't have to go into too much more detail than that. Step 1 isn't very heavy on the management, but for step 2, we'll definitely go into more detail. But if we're talking about anaphylaxis, we need something that's going to work immediately. And so in those situations, we're talking about epinephrine. Now, the other thing in the diagnostics, remember, you can also do skin testing in these patients. If somebody comes in and they say, "Doc, I'm just allergic to something, I don't know what it is," you can test all different types of allergens on the skin. And essentially, you're looking for these kind of reactions, right? You're looking for urticaria, edema, swelling, etc. Now, the last thing on here, I just want you to remember, because this has been coming up more and more in questions, are these non-IgE mediated histaminergic reactions. So it's just like it says. It means in some way, we're stimulating mast cells and basophils to release histamine, but we're not doing it through IgE. That's the important point. So is it truly a type 1 hypersensitivity? The answer is no, but you should be familiar with these. You just should know that they're not using IgE to cause this type of reaction, because again, everything is really based on mechanisms for step 1. So the first one here is vancomycin. This is going to be very classic for causing the quote-unquote red man syndrome, which is usually due to a rapid infusion. If a patient gets a lot of vancomycin really quickly, you can get direct activation of mast cells, basophils, and get degranulation. Okay, but again, not mediated through IgE. There's no IgE. It's direct stimulation from the antibiotic in some way or another beyond the scope of step 1. The other thing on here is radioiodine contrast is also very classic for this. And then very kind of low potency opioids can sometimes do this. And again, the presentation for all of these, it can pretty much appear identical to, what we're talking about here. It's just not IgE mediated. So when you see a question with vanc, radioiodine contrast, low potency opioids, and all of a sudden that patient looks like they're having a type 1 hypersensitivity or maybe anaphylaxis even, right? Just remember that these are non-IgE mediated, because that's where the questions come in.